Hi class, we're going to be going over some human growth and development starting with the early years today. Welcome to week 2 of our course. Um, I will be looking forward to reading your discussion boards and seeing all the things that you've learned thus far. This all goes rather quickly, so if you have questions, please don't hesitate to email me and I will get to you as soon as I can. So we're going to start off with Piaget. Some of this information you might remember from maybe other classes like lifespan development that you may have taken in your undergraduate courses. But Piaget's constructive theory, the human mind constructs its knowledge, child is active, participant in the learning process. And as we know with infants, like learning starts quite young, right? They start to adapt, they start some assimilation, taking in new information, accommodation, the process of changing knowledge structure to allow new information to fit. There's a lot the mind is absorbing from the moment a child is born, right? There's a lot to take in, even if it's basic things like, color, like sound, understanding, like we talk about this, like understanding when something's real or fake. There's like so much to there's so much growth that happens in such a short amount of time when you think of birth to even becoming a toddler to even becoming a child that's in elementary, right? There's so much that happens. We go from being little beings that need to be fed and taken care of and changed and nurtured. Nurturing, I mean, it still remains, but like so much dependence to becoming more and more independent, right? And that time frame, so much happens so quickly, right? If you have children, you may have experienced this. If you don't have children, you may have observed other people or work with children, and so you see these kinds of active changes happen. So Piaget, he was published by age 10, director of studies at a Center for Scientific Child Study and teacher training at age 25, wrote a lot of things on childhood development, used observations, hands-on problem solving and clinical interviews, recognized the role of teachers, and influential in all areas of cognitive development. Okay. Some of his controversial ideas is the assumption that cognitive development occurs in stages. The notion of overarching stages not supported by recent research, so things change over time, not unheard of or uncommon. Understandings of infants and preschoolers may exceed what Piaget believed to be possible, and learning in different domains is not always organized or structured in the same ways at the same time. So these are maybe some areas that people disagree with him on. And this is the beauty of our field, right? There is going to be things that you fully are like, yes, I 100% agree. There's going to be things you don't agree with. There's things that you're like, maybe I take that into consideration. We take what we feel like we agree with and we just don't take what we don't feel like we agree with, so you get to be the judge of that. But this is just some information for you to kind of take in and understand to see what you think or agree or disagree with. Okay. So the infant cognition, the sensory motor stage from birth to 2 years of age, Piaget's research based on inference from infants' interactions with the environment. Current research uses technology to make observations, which, I mean, granted, there's been a lot of technological advances since Piaget's day and age, not shocking. And so there's more data, different kinds of data, probably different ways of contracting that data versus how it was a long time ago. Understanding objects. So infants understand objects through their senses. So vision, hearing, taste, touch, smell. Object permanence, if the object doesn't exist when the infant can't perceive them with their senses. So like, for example, if you cover your face and they can't see you, then they think your face is not there, those kinds of things. We'll see this with kids. Like that's what makes peekaboo really fun. And or like if their parent like leaves, that's where you could have some separation issues. I don't know if they're going to come back, those kinds of things. So, because babies have a hard time understanding those things because of where they're at in their development. Remembering. So discoveries by research with information processing view of cognitive development. Recognition. The feeling that something is familiar when it's repeated. So like the baby in the womb understanding the mother's voice or is familiar. Like when I think of, I mentioned to you all that I have 5 children. I feel like as, obviously I had throughout my different times of being pregnant, obviously there became more voices because I'm around all my children. And I feel like even as the babies were born, especially as my house is never usually quiet, they were then used to their siblings' voices, which was pretty cool. Like they were familiar, and even I feel like they napped in noise because they were just used to hearing noise. My house is never, like I said, quiet. So they were familiar with their siblings' voices. They weren't like necessarily startled. Now, if the kids got in the baby's face or things like that, sure. I mean, it's startling to me still. But I mean, the baby was used to all the sound. Recall, remembering a past experience when it's not repeated. This emerges later in infancy than recognition. And these are things that you if you have had children or again experience any sort of level of children, you've noticed these things. So having an inferring intentions, may have intentions as early as 3 months, engages in means and behavior by 8 to 12 months. Child diverts attention from one goal to another and communicates somehow. Whether that be by crying, pointing, all those things. Shows evidence of developing executive functions and inferring others' intentions. So distinguish agency, the ability to act alone, and intention, internal and mental state. Rudimentary, I can't say that right. Rudimentary senses of others' intentions as early as 6 months, which is pretty impressive. That's, that kids like so young can start to figure some things out, kind of gauge what's going on. I think even get a sense of comfort from some people and a sense of discomfort from other people. They can sense how other people feel about them. It's pretty insightful considering how little they are. And, some children don't have a lot of vocabulary. So they're able to sense these things even if, they can't necessarily communicate it verbally, but they have a way of communicating it with, crying or maybe staying away from someone, things of that nature. It's very intuitive. Preschool cognition, the pre-operational stage, use of symbols as stand-ins for other things, so words and pictures. They have a tendency to focus on one feature or experience or event at a time. And further development of executive function. So working memory holds info we're thinking about. Self-regulation enables us to focus, suppress interruptions. And cognitive flexibility allows us to shift attention from task to task. So they're able to do a little bit more. They can understand numbers, understanding the mind, limited perspective, a limited perspective, taking skills in young children. So Piaget talks about the 3 mountains task that reflects pre-operational egocentrism. So centered on own perspective, which often for a lot of children, it is centered around their own world. Why wouldn't it be? Perspective taken as an aspect of one's theory of mind, understanding that people's behavior is a function of their internal subjective mental status. Use of mental words indicates awareness of mental states. Next, awareness that 2 people can want different things, like sharing, things of that nature. Later, awareness that 2 people can have 2 different beliefs. So these are understandings that start to happen. Obviously, language. Most aspects of language are learned by age 5. And this is where it's important as a parent, and you'll see this in counseling, and why doctors ask about language so early, because it's important to notice how now if kids are having struggle, I mean, obviously we're not speech pathologists, but if kids are having struggle with language, but they're listening and following instruction, they may understand, but they cannot speak, right? So there's a lot of, when we're dealing with kids who tend to be less verbal, we're trying to navigate what's really the problem. Is it a hearing issue? Is it an articulation issue? Is it they understand but they don't know how to use the words, or maybe they haven't been taught how to use the words? Is it something like a spectrum disorder that's going on? So there's a lot of different factors to rule out, and that's why it's really important for parents to be honest with themselves with what they're experiencing so that their child can get the right help. I know for my kids, they're all in dual language. So they go to school in Spanish, starting at a young age. My daughter is 4 and she's going to TK in Spanish. Kids in a lot of different cultures other than the US, like learn multiple languages, like from a very young age. And I think the younger that you are, the easier it becomes. And it is good for their brain to challenge them. And so, you'll see that in a lot of different cultures other than ours for whatever reason. So cognitive advantages such as brains responding more quickly when there's bilingual atmospheres. Now, sometimes that can confuse children, especially if like one parent is speaking one language and the other parent is speaking another language because they're not committed to one for some kids. So you have to be conscientious of the child and see if the child can handle it. But I think these are good questions when we're looking at intakes and seeing clients for the first time, is asking these questions, especially minors, young children, is what were they like as toddlers? What were they like as babies? Were there any complications? Were there any concerns? Because that might play a role in what's going on currently, you know, all these things matter. And so it's keeping that in mind. It's not being judgmental of parents. It's not being judgmental of a child. It's just trying to better understand, like, let's see the whole picture of what's going on here. Language is learned by, you know, obviously repetition. What attracts infants' attention helps language development. Elaborative, reminiscing, and narrative practice promotes autobiographical memories for children. So telling stories, things of that nature. I think the key thing is, and we were in the experience this with my first son. I mean, it's my first kid. I don't know what I'm doing. And so I didn't realize like I had to like teach him how to talk kind of. So there was some concern about language or him not talking a lot. And we had to be told like, no, you need to like make him repeat you, like, you know, things of that nature. And then he started talking and now he doesn't stop talking. But it's one of those things where I think kids, they just don't necessarily, I mean, they may pick up on words, but they don't just necessarily speak in sentences. You have to make them talk. And if they have siblings that talk for them, you're going to see them not speak. We'll see this a lot with children who have older siblings, things of that nature. So it's just making sure that you know, if parents are concerned, like, how are you demonstrating language? Who's speaking for them? Is it older sibling, like just meeting their needs because they know what they want? Because kids have a way of doing that for their siblings. Oh, this is what they want, they told me. And they understand how maybe they're speaking, but nobody else understands how they're speaking, things of that nature. So anyhow, those are all some things to be aware of and to ask your clients about, because the clients can have serious concerns, and you can kind of coach them through this a little bit. Always suggest medical evaluations and things of that nature, because we are not doctors, but that's something for us to consider. Okay. So we're going to talk about some social emotion. I'm talking too fast. Social emotional factors. Okay. So functions of emotion, there's survival skills, the motivation, the conscience, means of communication, enhance cognition, promote mental health. We also want to talk about emotional intelligence, the ability to perceive emotions, differentiate among them, manage them, and controversy about what emotions are agreement. They are experiences with physiological and interpretive components. Are there basic emotions? Well, there's universal basic emotions across cultures. Facial expressions can say a lot, right? We know that by some stink face, right? So, you know, but a lot of cultures, even young children, there'll be expressions of joy, happiness, interest, sadness, anger, disgust, fear, based on maybe experiences. And then, you know, they are usually based on something that's pleasant, unpleasant, and they grow and change as a person develops. The view from neuroscience, structures from the brainstem to the prefrontal cortex participate in the coordinated production of emotions. Low road processing, fearful stimuli bypass cortex. Quicker, less rational than info processed first via the cortex, may result in fear conditioning and require new learning or extinction training to extinguish. in neuropsychopathology, if you have that class or whatever, you're going to talk about these kinds of things a lot, about the neuroscience of it all. There's a lot to do with that. If you have ever any interest in trauma-based things, there's a lot to do with brain chemistry and how trauma affects our brain chemistry. Even for clients maybe who are victims of like a traumatic brain injury, maybe some veterans, you're going to notice some brain chemistry shifts, and that affects mood and emotions as a result of trauma to the brain, like it being hit really hard. This is why we talk about serious things with concussions, why we try to protect people in sports, because of what too many concussions can do to the brain and how it alters its chemistry. How do emotions develop? Okay, so emotions at birth, so there's distress, contentment, disgust, interest. It's pretty basic, right? By 6 months, anger, surprise, fear, and sadness come. 18 to 24 months, you have self-conscious emotions, pride, shame, embarrassment, guilt, empathy. And 36 months, you have a full range of emotions. You see your child with a gamut of emotions that probably alter rather quickly. Infants begin to recognize another emotional expressions, and it gets better as they age, right? And so emotional regulation, the cornerstone of an emotional well-being. There's a lot of adults who aren't emotionally regulated, let alone children. And so emotional regulation will be something that you will guide clients through, whether they're children or adults, because emotional regulation sometimes is not necessarily something that you just have. It's something you kind of learn, and we learn different soothing and coping skills. Some of those can be positive, other of those can be negative, and so we have to be mindful of that. So the process of learning emotion regulation begins in infancy. And so it talks about caregiving. So if your caregiver is emotionally responsive, and you get your emotions tend to, there's a level of soothing. So how it works between a mother and the infant or caregiver. Still phase paradigm tests. That's when the infant uses other directed coping than self-directed coping. And how normally when we talk to babies, right, our voice tone, like those kinds of things. So if you're very cold, there's a study that they do, it's actually rather sad, but it's like with a monkey, and there's like a monkey who is in, like, their mother is like all wire and isn't nurturing or whatever, and it's hard for the monkey to like kind of connect with that mother versus the one who has, like, I think it was a stuffed animal or something. It was like more cozy, all the things. And so there is something about being nurtured that matters. And you see this in animals. We're going to be talking about Bowlby right now, who is like the father of attachment theory. And it's very sad, honestly. Attachment matters. We see this now very clearly. There is full-on therapies that are based on attachment. Becoming Attached, great book. But first attachment, infant's connection with primary caregiver, whoever that may be. And that's where we talk about attachment is very interesting when primary caregivers aren't available to be there, maybe really struggle with postpartum, maybe a child is abandoned and left in the system. Those beginning days really matter. Back a long time ago in the hospital, when a woman had a baby, the baby went to the nursery. Now we're all about skin to skin, the baby being with the parents, listening to the heartbeat, all these things, because they matter. So anyways, 3 purposes or functions of attachment system: proximity maintenance between infant and the caregiver, secure base for ongoing protection, safe haven for stress management. It helps keep the baby calm, provides social context for interpreting problem behaviors. It just really helps. Like, proximity matters. It helps the child. It, I think, helps the parent even to some degree. It helps with a bond, and for the baby to become attached to the caregiver. Attachment to caregiver emerges in stages over the first 8 months. Strong preference for one caregiver by 6 months, and separation anxiety and stranger anxiety by 8 to 9 months. Okay. And this is the thing, like, I think a lot of times, very stereotypically, men can feel out of place when it comes to this, because If a woman's nursing or breastfeeding and then they've been carrying the baby, there's a level of feeling not attached to the baby. And so just strong efforts have to be made to feel that attachment. When you think about how do you get to know your best friend, it's not the first time you met them. And even for women, this pressure of like, I had a baby, why don't I feel connected? It's like, well, I mean, you just met him. So it takes time. And, there's other factors that can get in a way of that, which makes things complicated. But I think it's a level of you have to try to stay connected, not putting too much pressure on yourself or make yourself feel guilt and shame that you don't automatically feel connected, but that it's a process and it's a learning process for both baby and for both parents. Okay. Biology of infant attachment. So there's hormones called oxytocin. That's something that we feel in a lot of different ways in our body. We'll feel oxytocin in a climax. We'll feel oxytocin when nursing. We feel oxytocin after delivering. In parents, and promotes caregiving. This also helps with bonding. This depends on, all the factors that were involved in early on in the experience of delivery. Connects to other hormones like dopamine. And it can be a rewarding feeling, sensitivity in mother's caregiving affects how brain structure and functions develop in infants. And this is where, like, if a mom is struggling with postpartum depression, anxiety, all the things, they need support and help, because there's a lot of shame and guilt sometimes affiliated with that. And, this will help with bonding too, because the bonding matters not only for mom, but it matters for baby and their development. Attachment quality, not all attachments are alike, which, secure attached, show distress when separated from mother, eager to greet her when she returns, see mother as a secure base. Anxious, ambivalent, insecurely attached, shows distress when separated from mother, cry more than other babies, act angry when mother returns. Avoidant, fail to cry when separated from mother, avoid, ignore her when she returns. Unemotional. And disorganized, disoriented, insecurely attached is contradictory behaviors, approach for comfort, avoid when she approaches. And so you can see all these attachment issues in adults, that struggled with, for whatever reason. I'm not blaming the mom necessarily at all. But attachment matters, and we see this in grown-ups and like issues that it derives in some of their unhealthy behavior as a result of the lack of attachment. Insensitive parenting, two major categories of insensitivity is intrusive and neglectful. So high rates of insensitivity among depressed mothers, neglectful care, understimulation of infant, reduced eye contact, infrequent holding, interference with infant exploration. Physiological markers, less laughing, more fussing, more negative emotions seen in the infant. Intrusive mothers may be harsh, coercive, or abusive. These are things that we have to be monitoring for as therapists, as clients come in our office, and things that might be happening. Okay. Infant temperament. Emotional and behavioral characteristics. If you have children, you see they all have different temperaments, or if you know children, you see them like growing in the same family, but they're all different. If you think of your own child rearing and maybe having siblings, each of you are different despite being raised in the same household. So traits: fearful, reactive, negative emotion activity level, positive affect, attention, persistence. Biologically based, genetic. There is some factors that are genetic. That kind of like you see people, in your own family, and you're like, oh, this person reminds me of this person. Genes and environment result in difference in brain functions, and study of 3-month-olds categorized as easy babies, slow to warm, difficult or fourth group of variable traits. Genetic vulnerability exhibited by difficult babies, more benefit from positive parenting, more harm from negative parenting. And so, this is where and maybe this is a newer school concept and some people would really react to this, but this is where you have to accommodate, your child to what your child needs. That doesn't mean they get away with things, but you can't necessarily parent every kid the same, because every kid is different. And so just things to be mindful of when you're talking with clients and they're frustrated with kids or they're frustrated with young children and it's not the same. It's because not every kid's the same. Not every person's the same. We can't treat them all the same. And so these are things to really be mindful of as we're talking with families, as we're meeting with parents, that we have to, if we're in a classroom setting, there's great therapies. PCIT is a great therapy to work with children and parents together, to work as a team. But there is a lot that can be detrimental if parents aren't willing to like work through like maybe their frustration and navigate. They might have to do things a little bit differently. Okay. So temperament plus caregiving, affect, attachment, security, great emotion regulation in babies with sensitive care, great challenge to provide sensitive care to difficult baby, greater ability of some mothers to respond sensitively. So temperament traits linked to attachment quality in first year, affects largely the result of their influence on quality of care. Specific traits affect kind of insecure attachment that forms, and traits make infants differently susceptible to positive and negative care and formation of attachments. And I'm going to wrap this up right now because due to time, but I please look at the other chapters, but I just want you to know we're not here to blame people. We're not here to shame people. Knowledge is power. And so our role as a clinician, because I want to get back to that, like, yes, we're learning this information, but how is it going to apply to you as a therapist? Our role as a clinician is to educate people sometimes, and knowledge is power, to allow them to feel empowered to make change, to allow them to admit to maybe mistakes or things that they need to do differently. And those differences can be lifelong generational changes for a family. And again, it's not to shame their parents. It's not to shame the way their family's always done it. But sometimes what always we've done isn't working, and we need to adjust and we need to change. If we know we have postpartum with one kid, we might have it with another kid. And so how do we be prepared? How do we know, like, okay, like, I don't need to be fearful of this. I just need to know the supports that I can utilize. Those are things that you will talk through in therapy with clients. And so I want to empower you to take all this information and not to feel shame even in your own experiences or your own parenting, but how you might make changes even for your current situation or in the future, or how you might educate others. So hopefully this is helpful for you. Attachment's huge. It's a lot of what you're going to learn even for dealing with adults. It's a lot of issues we see in relationships, because attachment does matter, and being securely attached matters. So I hope this is helpful. I hope you have a great week. See you soon.